All right, Laura, we're at 11:06.
All right, you want to
Ready
take
to
it
get
away,
rocking and
Monica?
rolling? Yeah, we're
Yeah,
ready.
you
All
take us on.
right. Well, Gretchen, your name isn't Ben.
No, we don't. I don't know why that happened. No clue. He said, well, "I'm his long lost sister." That's what happened. Is
Well, I'll take it, but I'm like, wait a minute. That's not
that's
Ben.
not. Yeah, that's not Ben.
That's if okay. Well, we will get that changed once Hannah hops in the room. I think she has control. So once she hops in the room, we'll get that changed. So welcome everybody to our monthly collaborative care special interest group through CFHA. We are glad you are here as usual. Quick housekeeping. Well, let me introduce us first. So my name is Monica Harrison. Then we have Laura Sadari and Ben Hilliard. So we are your leaders of the SIG group for this year. Quick housekeeping. Call for papers for the CFHA conference is coming up. I'm forgetting the day off the top of my head. I feel like it's the 15th, 14th, something like, is it the 15th?
It's the
Oh,
15th.
how did I remember that? I don't know. But call for papers for the CFHA conference that's happening this October in Raleigh, North Carolina are due by the 15th. I encourage individuals, sometimes it feels daunting because you're like, oh, I don't want to do this by myself. Pair up. There are other people that have interests similar. Last year, we paired some individuals up. Those individuals, one of those individuals is presenting to us today. So pair up. It pays to pair up. Like, what are you interested in? I have this. Here's what data I have. Here's some preliminary information I have. So pair up. There's strength in that. And actually, most of the proposals want to see that there's a mix of organizations, a mix of disciplines, kind of the whole nine. So if you need any help as you pair up or partner up, please let Ben, Laura, or myself know. If you're looking to partner with someone on something in particular, we can try to get you connected to some folks. But those are due March the 15th. And so we definitely want to make sure collaborative care is represented well at the conference. I will say North Carolina this year has a big push, and I see Eric is on here, has a big push around, oh, Katie's on here too, has a big push this year around collaborative care. So I think there'll be a lot of interest, a lot of people there wanting to talk about collaborative care and talking about some of the innovative things that they're doing. So if you have not presented already or thought about submitting a proposal, please do so. All right. So today you're in for a treat. As I mentioned, last year we had two people partner up, Kristen and Gretchen, who is here to talk to us today. Gretchen Jacox is a licensed clinical social worker. She and I have paths crossed for decades now, working in early childhood, also working at FQHC, and now, and I'll let Gretchen talk more about what she does. Gretchen's at Novant, so doing a lot in women's health, and is going to be talking to us today about their collaborative care program and what they're doing around perinatal collaborative care. So, Gretchen, if you could more formally introduce yourself, because I'm just going to say you're great. So, if you can more formally
Thank
introduce
you.
yourself, so individuals know the scope of what you guys are doing over there at Novant in Charlotte, North Carolina.
Yep. So again, Gretchen Jacox, have a LCSW and an MSW in education as well. An early childhood background, as Monica stated. And I've been working for Novant, hitting my 6th year in April. We'll be starting 6 years in this program. We started out with 5 pilot programs for doing CoCM in different clinics. And at the end of our year, there were 2 of us standing. I was one of them, gratefully. And so we built the program from the ground up. And it's a perinatal office, so it's a OBGYN office. And so I see, you know, all walks, so women who are pregnant and postpartum, as well as women who are just gynecological patients, and the transgender in that as well, which has been an interesting twist for me. So we started collaborative care day one when I first started, and it is thriving now. I mean, of course, in the beginning, the first year is always tough, of kind of getting people on board. But give you a quick breakdown of our clinic. We have 18 providers in our clinic. I think there's like nine docs, and then maybe it's nine doctors and like six midwives, and the rest are nurse practitioners. And so they're all working in women's health with us. So I looked at what Ben was asking, and I kind of added some stuff in. I've got like, I don't know, maybe 10 slides. I kind of pulled some stuff from our presentation. But I really want to focus on what you guys are wanting to know about the way that we run our clinic, and how we've gotten it from, rags to riches, so to speak, within this time frame. Because it's been interesting. And I think COVID was really a game changer for us, quite honestly. And I say that because I am fully remote. I am not back in the office. I was in the office for 9 months. And then when COVID hit in March, everything changed, and I was, obviously sent home like everybody else was. But instantly, like, my caseload built. And I think that was because nobody had to go to the office. So moms with kids already, moms who were pregnant, nobody had to drive. And if y'all know Charlotte, if you don't want to in terms of traffic, because it takes 30 minutes just to get anywhere. Like, you could go 12 miles and it take 30 minutes. So imagine being in a surrounding city, because we have a few that kind of are close to us. And Providence OBGYN with Novant Health is one of the biggest, it's actually the biggest practice we have in Novant, with the number of providers that we have. And people will drive an hour and a half to get to visits at times. So if you can think about that, for like a 30-minute visit with me or a 45-minute visit with me, you're driving longer than you're actually seeing me. And so once COVID changed all that and I was remote, numbers picked up. And then once we went back to, being back in office, two things happened. One, we ran out of office space, so there was no place for me to even be anymore, because our practice was continuing to grow. And so my office was taken over by somebody else. And then two, it was like, why, like, don't break what's already working. Like, why would we change it? And so that was the dynamic that I had to get used to, because I was used to being, patient facing and in person, all the things. And so had to make a lot of adjustments there, learning how to read different cues, because I can see what you can see from here up is all I'm seeing, and having to really navigate facial expressions and eye changes and head changes, and different body movements and annotations in words, and am I catching you crying, and all these things that you have much easier access to in person. So that was a big shift for me personally. And maybe some of you are asking, like, how do you manage 18 providers? It's because not all of them refer. That's just the bottom line. And that's fortunate and unfortunate, right? We look at it both ways. Um, as I said in our conference, the majority of the people that refer are the midwives. We have several of those that are my heavy hitters. And a couple of the doctors that were heavy hitters have left and gone to other, one of them moved to a different Novant practice, and one of them moved out of state. And they were two of my bigger referral sources. And so with them being gone, I have definitely noticed the hit there. And so we've hired a couple other folks. We have one person that's now a hospitalist in the office, I mean, in the hospital. And so I don't see her, but she actually does refer to me, which I think is great. And so one thing that I will say is, if you're working at a hospital and you have a person that can be there to do referrals on discharge, that's really super helpful, in terms of just sending me a message and saying, hey, postpartum check in 2 weeks. She's, feeling anxious about going home with this baby. Can you check on her? And so I will give her a chance to get home, and then I'll call a couple days later and say, hey, are you interested in getting in to be seen? And 9 times out of 10, it's yes. And so the lovely thing about that is that a patient that would necessarily only be seen in 6 weeks is seen 3 times in 6 weeks, because I see her every 2 weeks until her 6 week visit. And then I'll continue on. And so it changes that dynamic of eyes being on somebody, that could be really turning quickly, in terms of depression, anxiety, etc. Um, so, um, so with me being remote, schedule just built really quickly, and I have, like I said, my main referral sources, and that works for me. I generally average, generally, it's not been that like that lately, but 25 to 30 people a week, which is steep, and it's a lot, and it can be, depending on whether it's an hour or 30 minutes. There are days where I kind of have your traditional, like, 8 people, and it's all hour visits, which I'm not a big fan of, because I feel like that's more like traditional psychotherapy. And although I love doing what I do, that's draining, because inevitably on those days everybody decides to show up. So it's like back to back to back to back all day long. I'd much rather have back to back with 12 patients that are 30 minutes because it just goes by a little bit quicker and we're not getting as in depth and it just works better for me personally. Um, but it's been good. And, I consult with our psychiatrist every week, and we triage patients and talk about what's working, what's not, and then go back to the patients and talk about what's working for them and what's not to make sure that we're just staying on top of scores changing or not changing, and patients either getting better or not. And so that's been it's a very well oiled wheel and machine at this point. And all of our doctors are very well aware of me and talking to their patients about me, and there's signage all over our office that says that I'm available. And I send out sometimes, like, this is a slow week for me, next week is a slow week. I send out a message ahead of time that says, hey, I know you're coming in to see your doctor in the next week. I noticed that your scores for depression and anxiety over the last year have been, at some point, have been low. Are you, or hi, I'm sorry, are you interested in scheduling with me? Do you need any additional support? And sometimes that generates 5 people, sometimes it generates none. It just depends on who's coming in and who feels like they want support and who doesn't. And so that sometimes that can be a really helpful tool. And other times it's frustrating because, like, I've gotten one hit for next week and that's it. And I wish it was more because that makes my days go by longer when I don't have a fuller schedule. But sometimes things just kind of pop up out of nowhere and people will call in and get on the schedule. I mean, I schedule the majority of my patients, probably like 95% of them myself, through the referrals, excuse me, and rescheduling after seeing a patient. The front desk will do the folks that I don't catch on the phone, and they'll call back or message back and say they're interested. And those guys, I don't call them. I will send them to the front desk and they'll call them to schedule. So again, well-oiled machine that works really well. So we have two OB providers, myself and another young woman who we hired a couple of years ago. We have two family practices, and then we have some folks at our two of our Michael Jordan clinics, which are just what they say, they're for low income. Michael Jordan has funded those in Charlotte. So they're basically kind of like under or uninsured folks, so high Medicaid population or inability to pay. So those folks are seen. And so we have two people in two of those clinics. So I guess we have like 6 people at this point that are kind of our health behaviorists, is what we call ourselves, because we're kind of looking at the full scope of a person holistically. So it's not just depression or anxiety. We also look at blood pressure or sleep or, any of the other things that are kind of on the registry. However, I don't usually get those. I get smoking. That's what I get. That's the only other. Nobody asks for, diabetes management or anything like that. It's always smoking cessation. And those generally last, I don't know, maybe a month or two, and then they drop off. So that's kind of generally who we see, kind of what we see. So I'll ask if anybody has any questions now before I jump into my presentation, because I don't have to do the presentation at all. It is there if it's
Listen,
needed. I just had it because I was like, holy crap.
nothing wrong with the presentation because that
No.
sparks more questions, but you actually do have some questions just
Oh,
from
good.
you
Okay.
talking. Like I have a question, but I'll save my question and allow my fellow colleagues here that did the right thing and put their stuff in the chat to get theirs answered
Okay.
first. So one question came from Liz is, do all of your clinics OB patients deliver at the same hospital, or do you have to coordinate with multiple discharge planners like from the hospital? Like how does that working for the coordination of everything?
Yeah. So the easy answer is yes, they all mainly deliver at Presbyterian, but there are people that are farther out that don't make it to Presby. They will make it to one of the surrounding hospitals like Huntersville or Matthews, which are just kind of 30 minutes from our main office. But the majority of the patients do deliver at the main hospital. However, we don't use care coordination from there. Usually it's the doctors themselves or the midwives themselves that are sending me direct messages. We don't have a person there that, says, hey, I saw this person up on discharge and they need blah, blah, blah. That's happened very randomly. And it's been more of a social worky kind of resource referral question versus a direct like mental health support issue. And so we don't have like a separate person that deals with like discharge planning aspect of our patients. They all are just seen by our physicians and our midwives that deliver. And then they will, upon discharge, send me messages to let me know that person is asking for extra support.
Gotcha.
Does
I'm
that answer your
wondering.
question?
Oh, let me ask, Liz. Where's Liz at? There you go.
Ah,
Liz, this
I gave you my thumbs up emoji. Thank you.
Oh, I see. Yeah.
I'll take it.
Okay.
How does that work with your patients as we're talking about discharge planning and all that? How does that work with your patients that have like traditional PCP somewhere else, or do they not? Are all of them like just primarily come to your OBs?
Yeah, so our collaborative care is only for our OB office. So it doesn't entail a primary care. If that person has a primary care doctor, and let's say we're talking about medication, for instance, um, the person will say, especially if it's like an ADHD med, because obviously our OBs are not going to manage that. But some medicines, either the patient's coming to us with it already being prescribed by their primary care, or they'll say, can my primary care, can you touch base with my primary care doctor because they're going to be seeing them longer? And I'm
Hmm.
like, no, like we don't do that direct collaboration. I said you can, if your primary care doctor is a Novant physician, they can see all the notes that are in the chart regarding the care that you've had while you've been in our office and what our suggestions were in terms of medication. But I've never had, I want to say never. I think I've only had, over the course of the years I've been here, a couple of consultations with primary care doctors just out of concern of something that's going on. And so
Hmm.
I've only had a few doctors that have requested for me to say,
Have
hey,
a
can you talk?
conversation.
Yeah, can you talk for a few minutes about this patient? That hasn't happened very often. So we generally don't deal with any of the primary care doctors. We don't see them. We don't communicate with them unless there's a direct question that they have because they're not understanding our plan of care.
Gotcha. Okay. So then you had mentioned something about hospitalizations. And I don't know, Eric, if you're in a spot to come off. So Eric had just come off of mute. So Eric had said when thinking about discharges, the HEDIS 2025, which Laura dropped in the chat there for everyone, satisfies. Because I was like, what is a FUM? Eric, are you cussing at me? And Eric and I know each other, so I'm just messing with him. But I was like, what is a FUM? But it's follow up for mental health inpatient discharge. So it looks like there's some information there that Laura dropped the chart in that Eric had referenced for how collaborative care could help with those endeavors as well. As you're talking about getting referrals from the hospital for follow up and some of those things. So that's a
But
big
remember, it's a hospitalist that's directly related to our office. It's not just a random hospitalist in the hospital. It's a person that was hired by Providence
in
OBGYN. It
place
is
there.
on their staff and is only in the hospital. Yeah, and so um, yeah, so the one thing I will say is like we have had a handful of like postpartum psychosis patients that I have treated that have then ended up going to the hospital, going to like Chapel Hill, which is one of their, that's for the more severe um, patients. And we have done some coordination there with like making sure the patient gets there and then make sure the patient is discharged, that they're getting sent to somebody that's within our area. I haven't done as much of that specifically, but there is some kind of care coordination around that because then those patients are either seen, they're generally not seen back in our office because our psychiatrist is not going to handle that. That's going to be a psychiatrist outside of our office that is going to handle follow up from a hospital discharge, a mental hospital discharge for psychosis. That doesn't happen often. I mean, I was just saying, telling somebody that thankfully, I think in the 5 years I've been here, going on my sixth, I've had three that I'm aware of that were ones I was treating. So either I'm not aware of it or it's not happening as often. So we do a little bit of coordination there, but not a whole lot.
Hey, Laura, did you want to say out loud what you had put in the chat about how this is kind of helpful to consider for moving forward?
Yeah, there's a lot of ways that we can show value, and one of the reasons why this HEDIS measure may be a consideration is a way to show value-based care, value-based payment, value added. In the past, for like that follow-up for mental health concerns in the emergency room, there were limitations to the HEDIS measures on needing to have specialty mental health follow-up. And I know for like my care system, we did very poorly on that due to a lack of availability of specialty mental health. So from the primary care perspective, Now in the 2025 HEDIS measures, they are counting collaborative care model in primary care as a qualifying follow-up, within that limited time frame for that HEDIS measure. So something just to keep in mind.
Yeah.
Yeah,
Yeah.
yeah, you may not like go after having that as one of the measures with any one payer that you're accountable for. However, they're accountable for it, and it's going to impact your overall total cost of care and other factors. So just being able to satisfy that by having the CoCM service running for that particular patient, definitely is a win-win. Um, and even peer support now is part of that, which I was a little shocked by that a peer support specialist can be the person qualifying for the follow-up after ED, but
Hmm.
it is on the list.
Gotcha.
Just because their experiences and training vary so much, but not to discount their
Lots of
value, but
contact.
it's just surprised to see that change.
Yeah. Big change. I feel like there's been a lot of changes here lately about things that they've said we can start trying to bill for, like in general regarding teams and integrated care. It's been pretty unique. Gretchen, you have two other questions as well,
Okay.
and then still mine that I'm waiting for last. So, what is your preferred caseload size for your OB practice? Like, do you all have one? What does it look like? If you don't have a set one, because some places do, some places don't, what does it look like in general of a caseload of patients for collaborative care?
Yeah, so we do not have one necessarily set at the office. I know that amongst our behavioral health team, we've talked about like number of visits daily that would be helpful in terms of sustaining salary, and that's usually like 5 to 6 people daily, depending on what kind of service you're providing. But remember, we're we're our collaborative care looks a little different because we see people a little bit longer. Like, so we don't always stick to the 15 or 16 minute 30-minute visit. We because lots of times these women, even though they may not come in with like severe symptoms, need to really process a lot of what's going on when they're making transitions into pregnancy, unexpected pregnancies, pregnancy loss, and then the transition into parenting. And so, which is this part that I love the most is, Monica, that like just the parenting piece to me is so much fun. And so a lot of our visits are like 90837. It's the traditional psychotherapy visit because we don't bill psychotherapy codes. So, I mean, the collaborative care codes. So you might ask why, like big question mark, because we're doing all the other things. It's because when we started, collaborative care codes weren't a thing. This is back in 2019. They weren't available. And so once we got our machine well oiled, we didn't want to change a whole lot of that. And so we have not switched over to looking at whether a collaborative care code would be more beneficial financially for our program at this point. And I know, Laura, you and I talked about that 2 years ago when I met you, because I was like, oh my God, like I want to know how you do all the things. And I remember you said, like, take one person, two people, and just kind of look and see. And I've mentioned that a couple times, but seeing and doing are two different things. And finding the time to get it done, or like pulling stuff from, I don't know, a past billing cycle to look to see what it would look like takes a lot of effort, and we don't have a huge team that can actually do that. So other people that have come on since I have been here, and since collaborative codes have been accepted by lots of insurances, et cetera, those folks are doing more of that collaborative care billing, and including all those minutes for different collaborations, et cetera, versus me, who I would say I'm lucky because it's a little bit easier. I'm just sticking to the traditional psychotherapy codes, and so that for us is very lucrative. It supports my salary 100%, which is pretty impressive. And I think we're not in the red, but we're barely in the black. It's like I'm not producing a significant amount of money, but the support is significant, right? And so it's of value enough to our office to do whatever we can to maintain my position there right now. So that's been helpful.
Gotcha. There's also a question around, do you utilize universal screening to trigger potential referrals, which kind of dovetailed a little bit into my question, which was going to be about engagement. So I guess engagement for me on two ends, the initial, right? Like how are you getting referrals? How are
Hmm.
you
Hmm.
engaging with your providers and the staff? Like what are you doing? And then also once you get those patients into collaborative care, what's your engagement look like to keep patients like coming for their
Yep.
appointments, all of that stuff.
Yep. So yes, we do the PHQ-9 as our main in the Edinburgh, obviously for postpartum moms or even pregnant, before they deliver. We do the Edinburgh as well. So a lot of referrals come from those sources. Whether and now that I think about it, what like way postpartum, as you know, a lot of pediatric offices are doing screenings on those moms when they come in with their babies for their babies visits at 3 months, 6 months, whatever it is, and they're getting flagged there too. So we have a another set of um, clinicians who have a report system set up in an Epic that if a provider puts in a high score for a mom when she goes to the pediatric visit with her baby, that automatically gets sent to them, and they automatically will send us a message and say, hey, this person scored X, Y, and Z on their Edinburgh screening at the pediatric visit. I saw that you were like had this patient on your caseload. Are you still seeing them? Do I need to give them a call to offer them services? Like, so there's that tie-in too. And for our clinic, a lot of them that they send to me, I either have seen or am seeing currently. And if I haven't seen them, like this kind of speaks to your question, Monica. If I haven't seen them in a while, I will indicate that. I'll say, yeah, they're on my caseload, but I have not been able to see them. Like they have canceled or no show their last two appointments, and I have not had a chance to rally the troops to get them back in. So please feel free to give them a call if they want services again. Please have them call the office or let me know, and then I'll have our schedulers reach out to them, because I know that's hard. Like, I mean, we should not expect our people to always call us, because new moms are just not gonna. It's gonna be hard for them to do that because there's a lot going on. So a lot of times I will try to kind of facilitate that and give those phone calls or send messages to our schedulers so they actually do. So that's another method. So we do the PHQ-9, we do the GAD-7, we do the MDQ if needed, we do the adult ADHD screening if needed, we do gosh, let me think. There's a few that we do. The PHQ-9 and the GAD are the ones that I do weekly or bi-weekly. I do those every 2 weeks when I see somebody. I send it out ahead of time so they get it before the visit. It's all electronic. And so it's automatically sent back to me. So by the time I see them the next day, I can make a note of what their scores are. And then that becomes part of our conversation when my first question is, how's it going? You know, and then, and I'll say, how's it going? Like, I see your scores are blah, blah, blah. Right. And then we kind of, that starts the conversation and into, I'm doing well, I'm not doing so great, this has gotten better, this part has gotten worse, I don't think the medication's working, blah blah blah. So then we kind of get into the whole dance of the conversation and the support there. So yeah, that's very helpful, because before we had it actually built into Epic, I was doing them during the visit. Like I would say, hey, can we get our screenings done first? And I hated that because I feel like that takes away time from the important aspects of what really it's important. I'm not saying it's not, but I feel like it takes 5 minutes of your time. If you only got 30, like that's precious time that we're doing. And some patients, as y'all know, will be, well, I was thinking, and then the screening takes 7 minutes instead of 5 because they're like wanting to elaborate on every single question that you're asking. So it's much better as a self-report. And that way I don't have to take time to do that. Randomly, every now and again, people don't do them. And so I do need to facilitate that within our visit. But yeah, so reoccurring engagement. Part of it, I think, is just how the engagement goes to begin with the patient. So if you come across as open and willing and helpful and supportive and empathetic and normalized and all the things that we're trained to do, they're probably going to come back. It's because it's helpful, even if a problem is not solved, just being able to say, I feel guilty because I hate this period of time. Like, this period sucks, right? Like, who said that postpartum or pregnancy was wonderful, right? Because people feel some kind of way about saying that, because they feel like if they say that they hate being pregnant, they hate their baby, they hate their life, they hate all these things. And I'm going, No, like not everybody likes being pregnant. Like it's okay to not like being pregnant. You have to separate the two. It doesn't mean that you don't love your baby or you don't love the fact that you're in this space in your life. And so just hearing that sometimes you can physically see the change because people feel so awful about having those thoughts and they're so scared to say them because it's so not what anybody wants to hear. Nobody wants to hear that your postpartum period is terrible, that your pregnancy is awful, because people expect you to say, oh, it's amazing, it's wonderful, this is great, like society says it is. And then when you go, it's not, nobody knows what to say. And so people put the mask on and they're like, hey, this is great, and it's fine when it's not. So I think that engagement, a lot of it is the normalization of how hard that period is, and grieving the life that you had before your child was born. That's a big deal for people. And they feel guilty about that too. Like, what do we do? Oh my God, like we have this kid now and it's not going back, but I can't go back to what I had before. And I'm missing not being able to sleep late. And I'm not missing being able to get up and just go to the grocery store. And I'm not missing not cleaning dirty diapers, like all those things, right? So again, a lot of normalization I think is beneficial. And I personally, me, like what you see right now is how I engage with people. I'm a very people person. I mean, I'm very, I don't know what the word is, not casual, but
Approachable.
authentic, approachable and
Authentic.
authentic.
There you go.
Authentic is like I try to be my true self. Like if you saw me on the street, how I am now is how I'd be in session. And so, I get down dirty with my women too. If they're cussing, they're like, excuse me, I'm like, for what? I do it too. Like, if you're feeling like that and it's shitty, then it's shitty. Like, so normalizing and being real, I think makes them feel like it's not therapy, even though it is. And so I think that pulls people back, especially if they're new and they're like, I've never done this before. And like, oh my God, this is so, anxious for me and I don't feel good about this and I don't know what to say. I'm like, just tell me how you feel. That's all you got to say. And then the conversation starts. And I think so it depends on the therapist and the approach from the therapist as well. Like that's a big piece of it. And having somebody that knows what they're talking about is helpful too. So I think all those things are pieces in terms of engagement, and getting folks to come back. Um, but as we know, not everybody comes back. And I don't have time to call like I would today. Like today, I could call several people because I only had a few people on my schedule. But other days, I can't call those that I haven't seen. In the very beginning, I did 100% because we're going to build caseload and build like an established, plan of care for these people. And for our clinic. And so in the beginning, I was calling people left and right, like, hey, I saw you missed your last visit. Are you wanting to come back? Doing that because other than that, I wouldn't have anybody on my schedule. And so that was something I needed to do. But now I'm very well known in our clinic, and I don't have to do that. So I might leave it up to like the schedulers. If I saw somebody that came across I don't know how this happened, but this person must have had an appointment. And I had sent the PHQ-9 and the GAD weeks ago, and she filled them out 2 days ago, and her scores were high. And I was like, but wait, I was looking at my schedule. I was like, she's not on my schedule. Like, what's going on? And I was like, oh, she must have had one and then canceled or didn't show up or something. And so I just messaged her and I was like, hey, I saw you did your screenings. Thank you so much. They're a little bit high. Let me know if you want to schedule something else, because I didn't want that to go unnoticed that she had high scores and we weren't paying attention just because she wasn't on my schedule that day. So I managed, and that's easy enough to send a message. It doesn't take long to do that.
In the
Um,
patient portal.
yeah,
Yeah. So it
exactly.
sounds like a whole host of different strategies for that engagement piece of things. Okay.
Yeah, very much
Well,
so.
Ben has his hand up
He
for a
does.
question.
Gretchen, can
Yes.
you be my therapist? You're awesome.
Oh, well, thank you, Ben. I don't know. What kind of insurance do you have?
Uh, no, it's all self-pay, you know. But,
Oh, okay. I'll take self-pay. Absolutely.
two questions. I've had friends and clients that became pregnant and had to come off medications. Do you
Mhm.
see that as a significant issue, and how do you address that? And also, do you see partners? Do they come in? Do you work with those folks as well?
So yes and yes. The first question, I think it depends on the meds, right? If it's a psychiatric med, sometimes I get frustrated behind that if it's one of the ones that's safe, because we all know that it's not in the best interest of the mom or the baby to not be on those medications. if they have a mental health issue that I was treating. But there are a lot of moms who get paranoid about harming their baby in utero while they grow with said medication. So when that happens, and I've noticed the dysregulation in their mood, if their scores are higher, et cetera, one of the things that I try to offer them is like validating concerns, normalizing that you don't want to be on these medicines, give all the psychoeducation on the benefits, and that most doctors would most likely not suggest that you be off of those medicines, because usually it's a primary care doctor that's like, yeah, you probably shouldn't be on that. And I'm like, are you listening to your OB? Are you listening to your primary care? Like, in regards to this, it's their specialty. But one thing I'll do is like a bargaining thing. I'm like, I get it that you don't want to be on it, but how about we revisit this at like 33 weeks and we see how we're doing? I said, because my concern is what's going to happen after you have this baby and your hormones are all over the place. And so, can we start at 36 to get it in your system by the time that you potentially deliver at 40, 41, and then you have support going into your postpartum period. So
Super interesting. Thank you.
yeah, a lot of them feel good about that because baby is well cooked at that point. And they're also feeling more comfortable about the education around, because usually it's going to be like Zoloft or Paxil or something that's fairly lightweight for them. And we talk to them about, and I give them like PDFs on like, this is what happens after delivery for you if you're taking this medicine in for your baby. Like, so they have that information handy to read through. Because I try to not let them make Dr. Google be their friend, because that can be a little anxiety provoking. And so I try to give them the information they need so they don't go looking elsewhere. And that will go off more times than not, that somebody will say, okay, 36, 37 weeks, I think I can do that. And they will feel more comfortable with that. The second question, yes, partners do come in. Generally, it's around a loss. That's usually when I have seen people together, because I don't toot my horn as a couples therapist, because that I am not. And sometimes I'll do transition. Like there's a couple I saw recently that had some difficulties with the transition from, you know, being engaged, getting pregnant, getting married, moving, having this kid all within like a year. And I was like, holy crap, like no wonder y'all are like, because it was just, they weren't even living together and they did all this. Like they got pregnant and were married and moved in and had this baby all within the course of a year. And so they were struggling after the baby was born. But generally it's around loss. It's if somebody had a late term, stillborn, or 20, 30 week loss for some reason. And we kind of just process those feelings, or unfortunate, a loss during delivery, which has happened. I don't think I've had any that have passed away after birth without the parent knowing that was going to happen. So that that's some kind of congenital thing. They kind of knew ahead of time. So I haven't had any like surprise. I might have had a couple of SIDS in the years, but that's about it. And yes, those I have seen both of those folks for 1 or 2 visits. It doesn't last long. It really, it's a lot of normalization of feelings and day by day kind of conversations about expectation when it comes to and grief, obviously. But I always send those folks information on. We have a local agency here called Kindermorn, and it's based on parents and siblings who lose children. So that's kind of the go-to spot. Not everybody wants to do that though. Like they don't always want to do the group therapy or the individual therapy, but I always give them a choice, because I tell them I'm not a grief therapist. Like I'm not trained that way. Have I been doing this for a long time, and do I know the nuances? Yes. But I also want you to know that I might not be the best person to provide you the support that you need, and I want to make sure that you get it. But you can talk to them, have a conversation, and then make a decision. Just know that I have limitations in that area. That's what I tell them. And almost every time they come back, and I'm like, okay, like, all right, just know what you're getting into here. But usually it turns out well, and folks eventually get into a better space, and then kind of fall off. So yeah, I
It's
do
probably
both.
your engagement that brings them back.
Authenticity.
So there is a question that kind of stems from you talking about billing your psychotherapy codes instead of collaborative care codes, which is not new. Like we know
Mhm.
that there are other practices you have to kind of weigh out for your organization from a financial standpoint, and a lot of things matter. Sometimes it's the reimbursement rate for collaborative care is low in
Mhm.
some states. Some insurances don't reimburse. All the reasons. I
Right,
know a
right.
lot of FQHCs will typically bill psychotherapy codes versus collaborative care codes. So the question was, being that you are providing collaborative care but billing the psychotherapy codes, how does psychiatry fit into the mix? So how are you and Dr. Clark, like,
Yeah.
how y'all do what you do?
So I mean, it's all. I mean, it looks the same. It's a consultative basis, right? We still meet weekly, and there's no additional billing for his services unless a provider that we're doing shared, teamwork with reaches out to him specifically about something regarding that patient. And every now and again, there'll be a bill that's generated from that consultation with the provider and Dr. Clark. And then the patient will be like, I just got this 200 something. And I'm like, okay, let me check because I don't know how that works on the back end. Like I know how it works for me, but I don't know how it works for him. I said you probably should not be getting that because it's part of our team and our consultative work with the collaborative care. I said, but let me check. And so usually when that happens, he'll talk to his billing folks and they'll end up waiving it because it was part of our consultation. However, if it's a patient that is not part of our consultation, like not on my registry, not somebody that I'm seeing actively, then that bill can absolutely stand because that's a different. Because they'll say, I never saw a psychiatrist. I'm like, yeah, but you asked about this, and then this person spoke with this person about X, Y, and Z. And so that's something that I have not dealt with often. Maybe, I don't know, 3 times I can think of that I've had to circle back and be like, so Janet got a bill today, and you know,
Gotcha. Yeah, I could see that happening. There are billing codes for psychiatry, right? Like we know that for outpatient psychiatry, but there are also some codes that have to do with more consultation, like when the psychiatrist talks directly to the PCP. In some states, there are codes specifically for that, which may be what's happening. So in some states, there are codes specifically for that because that time cannot be counted as collaborative care because that behavioral health care manager is not involved in that conversation. It's just the two of them. But there are other times, so maybe that's why that's happening. Who's to say? But for those who are just trying to figure out like how to make these billing of all these codes work, there are so many options. There is not like this is the only way that you could do it. A lot of it really depends on workflows, your organization, what resources do you have at hand? Some people have community health workers, some people like just all of the things. So that nuanced question around billing specifically could vary, but it sounds like what you're saying, Gretchen, is although you're billing the psychotherapy codes for your direct work, you all are still doing we're going to meet, we're going to talk about
every
these
week.
patients we need to talk about. It's a weekly thing. So you're still doing your systematic caseload review.
And I have a registry also. Like, I mean, I do all those things. Like, that's not different at all. It's
Yeah.
just we've tweaked it to fit our clinic and what our clinic needs
Yeah.
versus, you know, putting it into a box and saying it has to look like this.
Yeah.
So yeah, we meet weekly unless one of us is out of town. And and he makes medication suggestions to our OBs based on our conversations. He does that. I don't. Um, there'll be a time or two where he'll mention something to me and I'll say, okay, I'll go ahead and let this patient know that she can increase her meds based on our conversation. And so I will send a message to the patient saying, hey, talk to Dr. Clark. He said, yes, it's cool to increase, blah, blah, blah. Check with your provider to make sure they're okay with that, like looping everybody in. And so I'll be the messenger, but I don't ever make those decisions, obviously.
I just I just have a quick question, Gretchen. I'm sorry. That was my question about that. And I just want to be really clear because this is something that we're noticing. Um, your involvement with psychiatry is strictly related to CoCM. It's not a requirement of holding a mental health license, and a requirement of supervision of psychiatry of your LCSWs or LPCs or any licensed mental health professional. This was strictly from your organizational perspective, like this is what we're doing, this is the model of care, not regulatory state requirement.
No, it's absolutely just collaborative care and the way that we built that program, and it's kind of following the model for sure.
I appreciate it. Thank you.
Sure.
Molly, what state are you in?
Pennsylvania.
Ah, okay. Just was wondering. Just was wondering.
Would you
I
like to write a letter and advocate for some things?
We are always about advocacy. I would definitely say if you all are wanting to jump on, so we work a lot at the AIM Center, we work a lot with the American Psychiatric Association because they do a lot of advocacy specifically around collaborative care and all things coding for psychiatry as well, clearly. But sometimes what they are looking for as they're trying to plead their case and they're trying to do advocacy is clinics who are trying. What are the loopholes you're running into where it's not working? Or, hey, we want to get a higher rate. Help us. I forgot who just got added on. Maybe it was Florida just got collaborative care codes opened up, but their rate is so low, right? So it's things like this that the American Psychiatric Association is always having their advocacy people on top of. So if you're interested in like joining their efforts and like, hey, what do you guys need from us? It's like boots on the ground because they're always looking for people to share their experiences. Let me know and I can connect you to some.
Hospital-based conversions
Mhm.
and hospital-based just anything is currently the largest place in space that we in Pennsylvania serving, 1/12 of the population, need help with because this is like a regulatory nightmare, just the claim that because they're hospital based, now you need like more psychiatry oversight, not just CoCM, like you need beyond this. So that's my input.
That's
I
your
don't
big
want to occupy this place and space more than that. This is like Gretchen's time to shine. But that is huge, is the hospital-based conversion.
Gotcha. Molly, can you put your email address in the chat or send it to me and I can copy paste it? So that's all the questions that are in our chat. We are almost close to transition time as well, but if there is anyone that just has a burning question for Gretchen, now's your time.
I'm going to ask one. What are the biggest pain points for you? What are some of the frustrations in doing this work specifically to your population?
Um, okay, I'll be transparent again because somebody said I love transparency. I think that the biggest hurdle that I have right now is I've been doing this for almost 6 years. And it's I can do it with my eyes closed at this point, which is great, but it doesn't offer a challenge to me like it did in the beginning when I was really not familiar with a lot of women's health stuff. Like I knew anxiety, depression, PTSD, like I knew those things, but not in this group of people. And so the biggest struggle for me right now is I don't want to say the day to day because that sounds terrible, but it's just I think it's time for me to transition to something different. And so doing this regularly all the time can be draining, just from the mental aspect of like saying the same thing for 5 different people in 3.5 hours, right? Just that part can get, I don't say it gets old, but I don't really know what else to call it. Um, that I think that's probably the biggest struggle personally for me. The other is just sometimes I wish providers would work a little bit harder to refer because I know there are more women in the office that need the support that are not getting it. And I have recurrently asked for to make sure that I am being brought up in these provider meetings to say, hey, like referrals are low right now, like if there's anybody. And I think that part of it is I think a lot of our providers, I don't want to minimize them, feel like they know what an appropriate referral is. I would much rather them not know and refer and me go, let me find somebody else for this person because I think that they would be better served somewhere else. And so sometimes they won't because they're looking at the more kind of structured, the way that our program is always run kind of folks. And so I mean, not saying that I want somebody with 5 diagnoses, because I don't. But if I get them, that's still a billable visit, and I can still refer them somewhere else and say, hey, I think you're going to be better served at X, Y, and Z spot by another therapist, or I can help you find a therapist, because we have a network here, two actually, North Carolina. One is in the Tri where Monica is, and one is where I am here in Charlotte, where we can safely and privately post stuff like, hey, looking for a clinician for a patient that has blah 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 and has so and so insurance, needs virtual visits or in person, is in this area of the city, who can help. And then I get 10 people, because everybody, like all the therapists are wired into this network, and then I can do my due diligence and copy all those people, which is a little bit of work sometimes, and then send it to the patient in my chart and say, hey, here are the people that bit on our post. Call some of them, and if I know any of them, I'll go, hey, I know this person, they're good people, or I would stay away from this person because I've not heard good things about them. But check everybody else out, and do a consult and see if you can find somebody. And I've been super successful with that, at helping people find people that I would never been able to do 5 years ago. And so I think the hard parts are just the same day to day, like feeling like it's Groundhog Day in some ways. And just be ready for a different challenge, I think. But I mean, I love the work. Like, there are days where I'm just like, oh my God, this was a great day. Or when you have that one person that just lights you up inside because they get it. And you're like, okay, like we are on our way to like feeling better because I saw the light bulb turn on day during our visit. So those are the great parts. But the rest of it is, dealing with people that need to come in and don't. Like, those are struggles. Hard parts are when you have people that have super high scores and you're not quite sure what to do with them. Like, those are challenges. I had one yesterday and I'm like, oh God, she seems like she might hurt herself. Like, what am I going to do about this? Because being that, so actually, Ben, that's a good point. Me being virtual is scary in this work, because when you have somebody that is actively feeling unsafe, when they were in my office, I could literally walk them over to the ED. Now I cannot do that. I've had to do safety checks. I've had to call EMS because I am not there. And not in when people, when you call people and say, I'm going to call you back in 5 minutes, if you don't answer, I'm calling the police, and they don't call, then they don't answer, I don't have a choice, because I'm not going to just be like, oh, they're probably in the bathroom. No, like, I don't know what's going on. So I would say that's probably the biggest downside, is just the fear factor of what you're going to get in a day. And are you going to find somebody that is going to be that unstable to where you're going to have to really work hard to triage and locate people that can be there, whether it's a person that they're familiar with, or whether you're going to have to call, EMS or 911 or something like that to get somebody there to be helpful in a reasonable period of time. I've had to do that before, and like been on the phone with the police on the ambulance on one end and the patient on the other. And they were like, well, does she have a weapon? I'm like, do you have a weapon? She's like, well, I'm holding a knife. I'm like, you need to put it down. Like, that's not going to go well. You're already scared. So it's just this, and that's just super stressful. Or having psychotic patients that I've seen, like, visibly acting very inappropriate and scary, and then figuring out how to get them support that they need. So those are the downsides. But
Thank
I
you
mean,
so
overall, the
much.
work is great.
That's wonderful. Thank you.
You're welcome.
Yeah. So we are basically at time, but I want to thank you, Gretchen, for
You're
hopping
welcome.
on and sharing about your program and the great work that you guys are doing over there at Novant with Dr. Clark. And so feel free, reach out to Gretchen. She is on the CFHA SIG base camp if you need to reach her there. Happy Social Work Month to all my social workers, including you, Gretchen. And I hope that you all have an amazing rock star day.
And Monica, can I just say thanks to Gretchen for jumping in last minute and providing such a great presentation.
Thank you. Thank you.
Absolutely.
Yeah, no, I appreciate it. Anytime, as long as I have a little bit of time, I can figure something out.
We were able to squeeze in there. Thankful for your
Squeeze it
slower
in.
week was our benefit. That's what that
Absolutely.
sounds like.
100%. Absolutely. For sure.
All right. Bye, you guys. Have a good
Bye, guys.
day.
Thanks. Bye.